Heart disease is a silent killer, and its impact on Africa is a growing concern. The ticking time bomb of cardiovascular diseases, CVDs, in Africa demands our urgent attention. Professors Yellon and Mpiko, experts in cardiovascular health, shed light on a critical issue: the rising prevalence of CVDs and the unique challenges in treating them across the African continent. The United Nations Sustainable Development Goals, UN SDGs, aim to reduce premature deaths from non-communicable diseases by 2030. However, CVDs, including acute myocardial infarction, AMI, and heart failure, HF, are on the rise in Africa, posing a significant threat to public health. But here's where it gets controversial. While Africa is known for its youthful population, with a median age of just 19.7 years, it's facing an unexpected health crisis. CVDs, including stroke, hypertension, and heart failure, have become the leading cause of death, surpassing traditional infectious diseases like HIV/AIDS, malaria, and tuberculosis. The numbers are staggering. CVDs account for an estimated 17.8 million deaths globally, with over three-quarters occurring in low- and middle-income countries, LMICs. In Africa, the prevalence of ischemic heart disease, IHD, and related deaths is predicted to surge by 70% in men and 74% in women by 2030. So, what's causing this alarming trend, and why is it so challenging to treat heart conditions in Africa? Heart attacks, diagnosed as ST segment elevation myocardial infarction, STEMI, and the subsequent heart failure are major contributors to mortality and disability. The ideal treatment involves swiftly removing blood clots from the coronary artery and restoring blood flow to the heart within 6 hours, typically achieved through primary angioplasty, PPCI. However, PPCI is not widely available in most African countries. Instead, patients receive thrombolytic drugs, which dissolve clots but at a much slower pace, successfully restoring blood flow in only 60% of cases. This delay in treatment exacerbates the damage to the heart muscle. Furthermore, patients in Africa face additional hurdles. They often have limited access to hospitals, especially in rural areas, leading to prolonged transfer times. Once in a hospital, treatment options may be limited, and the population has a high prevalence of cardiac risk factors, including diabetes, high blood pressure, stroke, and HIV. Enter remote ischemic conditioning, RIC, a non-invasive, low-cost treatment strategy that shows promise in improving clinical outcomes after heart attacks. The RIC-AFRICA study, conducted in 2015, was the first to explore the potential of RIC in high-risk STEMI patients treated with thrombolysis. This proof-of-concept trial, involving 519 patients in Mauritius, found that those who received RIC upon arrival at the hospital experienced a significant reduction in the size of enzymatic myocardial infarction compared to controls. The cardioprotective effect was comparable to that seen in STEMI patients treated with PPCI. In 2019, the CANDI-2/RIC PPCI study, published in The Lancet, examined RIC's effectiveness on a larger scale across Western Europe. While it didn't improve clinical outcomes, it revealed an intriguing finding: the control group's mortality rate from cardiovascular death was a mere 2.7%. This suggests that low-risk patients, with access to optimal care, were treated so effectively that additional therapy showed little benefit. And this is the part most people miss. Following these studies, senior investigators called for this intervention to be implemented in developing countries, where patients face significantly higher risks. This led to the proposal of the RIC-AFRICA study, a large-scale outcome trial using RIC to investigate clinical outcomes in high-risk STEMI patients across Africa. The RIC-AFRICA trial began as a small pilot in 2022, assessing the feasibility of conducting such a study across multiple African countries. 20 hospital sites were selected in South Africa, Uganda, Sudan, and Kenya, with ethical approvals obtained from local hospitals, national regulatory bodies, and governments. With support from the Novo Nordisk Foundation, the study is now in its second stage, focusing on 17 clinical sites in South Africa, Namibia, Senegal, Mauritius, Kenya, Mozambique, and Uganda. The goal is not only to conduct the trial but also to ensure accurate and robust data collection from recruited STEMI patients, including those with comorbidities like diabetes, hypertension, obesity, vascular disease, and HIV. A complete medical history for each patient will be documented, providing valuable insights into the risk factors and comorbidity burden of STEMI patients in these countries. Additionally, the study aims to develop a sustainable cardiovascular research network across Africa by training researchers in data capture and safety protocols. This will enable future trials to address local healthcare needs more effectively. But why is this research so crucial? Cardiovascular research in Africa is still in its infancy, primarily focused on epidemiology and disease burden. Despite bearing a disproportionate burden of CVDs, Africa's contribution to global CVD research output is a mere 3%. It's essential to conduct research that fits within LMIC environments and capabilities, understanding the patient populations and clinical needs. This involves not only investigating disease pathology but also defining patient demographics and cardiovascular health challenges. The outcomes for heart disease patients in Africa and LMICs are worrying. By 2030, the prevalence of ischemic heart disease and related mortality is predicted to rise by 70% in men and 74% in women. For STEMI patients, timely restoration of coronary artery blood flow is crucial to limit MI size and prevent heart failure. However, PPCI is not widely accessible in Africa, and most patients rely on thrombolysis, which is less effective and slower. Other factors contributing to poorer outcomes in STEMI patients in Africa include inadequate access to hospital facilities, especially in rural areas, a high prevalence of undiagnosed and untreated cardiovascular risk factors like hypertension and diabetes, suboptimal use and compliance with secondary preventative therapies, and delayed presentation to hospitals, with 70% of patients seeking treatment after 6 hours of chest pain onset. As a result, inpatient mortality rates in STEMI patients in developing African countries range from 15% to 21%. The RIC-AFRICA study aims to establish new research foundations and capacity across participating African sites, breaking down barriers and fostering research networks and partnerships. Ultimately, it strives to save lives from heart attacks in Africa. Are we doing enough to address this growing health crisis in Africa? What steps can be taken to improve access to effective treatments and reduce the burden of CVDs? Share your thoughts in the comments below.